Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Stephanie Desmond talks to Dr. Paul Nestat, a Johns Hopkins physician and researcher who studies suicide and its causes. They discuss why we don't have a great handle on the causes of suicide and how interviewing the loved ones of someone who has died can help us better understand the risks. Please note that this podcast does contain mentions of self-harm and suicide. If you or someone you know is struggling, there are ways to get help. Call 988 for free confidential crisis counseling and referrals available 24/7. Let's listen.
Paul Nestat, thanks so much for joining me.
Thanks for having me.
So we don't actually really understand all the risk factors for suicide, do we?
No, I mean, we do have a good sense of some of the chronic risk factors. We know people are at higher risk if they're male or white, or if they have a history of suicide attempt in themselves or their family. These are the sorts of things that are chronic risk factors, but they're not great predictors. There are many, many, many people who are male or white or have suicide in the family. It doesn't help us decide who's at real imminent risk at all.
And why is it so important to understand that? And what are you doing to figure that out?
Well, it maybe is the most important question in suicide prevention, because knowing when someone is at imminent risk means we know when it's time to intervene. We do have really good, effective treatments for things like depression, which will be a major precipitant of suicide. But we need to know when people are most at risk. Sometimes, if they're really imminently at risk, they might need to be hospitalized temporarily, that kind of thing. But to do that, we need to know what we call the proximal risk factors, or risk factors that would be relevant right before the suicide attempt is made or the suicide is completed.
And so your goal in this research is to what? To get a better understanding of why people commit suicide?
We really want to get a better sense of what I described as proximal risk factors. We want to know what sort of indicators there might be that someone is imminently at risk. We want to know when someone dies by suicide, what were the missed points of intervention that we could have seized upon, what we can target interventions towards. If we know that, we can design those interventions and we can prevent suicide and save lives. I think it's worth pointing out, suicide remains one of the leading causes of death in the United States. It's the second leading cause of death among Americans under 40. And the rates have just been rising. They've gone up over 35% over the 21st century, such that the latest CDC data shows the highest suicide rate in the US since World War II. So this is an important public health crisis to tackle.
So I know that in the past, there's been research interviewing people who survive their suicide attempts. Has that been helpful? And where does that fall short?
Well, I think it has been helpful. We can get a good sense of what those people were going through. But I think it's important to distinguish between the people who have suicidal thoughts, who make suicide attempts, and the people who die by suicide, because epidemiologically, these are very different people. For example, just looking at demographics, women are much more likely to attempt suicide. They attempt suicide at 3 or 4 times the rate of men. And yet men make up 80% of all suicide deaths. The same thing could be said for age groups. Younger people tend to have more ideation and attempt, but older people tend to die by suicide. It's a different population, the people who attempt suicide, people who die by suicide. Most people who die by suicide have never made an attempt before. Most people, when interviewed in even the few weeks before they die by suicide, denied any suicidal thoughts. It's a different population, the suicide death. And of course, we can't interview people who have died by suicide, but we can talk to their families. We can work with the data that's available to us to sort of paint the most detailed picture we can of those last few weeks or days or hours or minutes of life by talking to collateral informants, family, friends, and by looking at every interaction they've had with any data collecting system, hospitals, the justice system, child protective services, and really get a good sense of, in those people who are going to die by suicide, what was going on, what could we have done that we didn't.
So these questions that you're asking, they're part of something called a psychological autopsy. Is that right?
That's right. That's a term that is a little confusing to people sometimes because the word autopsy throws people off a little bit. But at the end of the day, we mean we're looking at someone post-mortem after they've died, but we're interested much more in the psychology of that person and also sort of dynamic risk factors in their life than we are necessarily a physical stigmata of injury on their body, as you imagine in a traditional autopsy. Psychological autopsy is a methodology for looking at suicide that goes back to the 50s and 60s in LA, when the LAPD would use this to get a better sense of what happened when someone had died. But it's really become an important tool for suicide research over the 20th century and now into the 21st century. It's being renewed because we have new sources of data that can contribute to these psychological autopsies, things like social media history, which is more of an electronic record of what was going on that ends up being very helpful in understanding someone's inner mental life.
What are you learning from people when you interview them?
In the research studies that I'm doing using psychological autopsy, we usually have a specific kind of a goal in mind to look at a specific population of people or a specific type of suicide, because doing these investigations is resource intensive. It takes a lot of time. These interviews I'm talking about are 3-4 hour interviews. We want to talk to at least 3 or 4 people who've known the decedent. So depending on the study that we're talking about, we find different things. A study that we just completed looking at youth suicide, people who were young when they died, specifically by firearm suicide. Our goal was to get a better sense of how were these firearms attained? Were there sort of times when we could have intervened? Policies that would have made it harder to attain these firearms in these young people. And so we're learning a lot about the role of familial firearm culture in these families. Remember, these are people who died by gun suicides. They tend to be families that own guns and have opinions on guns in terms of how they view them, whether they view them as a dangerous object or something that protects the family. And so we're getting a good sense of that. What we're learning in that situation is that the common thread seems to be the gun is seen as a central part of the family's identity. In 2 of the cases, most recently that we spoke to, the firearm was actually either constructed by the decedent with his father or was a recent gift, something that sort of brings the family together, something you go hunting together with. So we're sort of addressing that cultural component. But we also find odd things that, at this point might just be hypothesis generating, might just be small things that we will later look into in more depth. For instance, of the first 9 interviews we did, the first decedents, and we sort of took a pause after 9, 3 of them had unique video game behavior before they died by gun suicide. All of them had been involved in multiplayer games with their friends. Their friends could report back on how they were doing. And all of them had been really killing themselves in the game on the day of their death with a gun. They would walk in front of their friend's gun when they were on a team in the video game, things that the friend would just find annoying at the time. Oh, you're getting in the way of us winning against the other team. But in hindsight, horrifically, they saw foreshadowing of this event. Now, we can't go around hospitalizing everyone who dies in a video game, right? But these are giving us some sense of the psychology and other sorts of warning signs that might be seen as part of a constellation of warning signs for a particular person. You're really worried about someone, they've been depressed, maybe they've been increased alcohol use or substance use, more withdrawn, and then you see them doing this in a video game, just enough to raise an eyebrow that you might want to talk to that friend and ask them directly, are you thinking about hurting yourself? How can I help?
What can we do with these pieces of information then?
I mean, that's exactly what you would do. You'd start to talk to your loved one. So, of course, this depends on who you're talking to. If you're someone's physician, then of course, right away, initiating treatment is an important thing. But if you're talking about just a friend or a family member who you're noticing warning signs, like I started to list before, withdrawal, low mood, maybe they might have changes in their behavior that might include substance use or alcohol, or might just be acting differently. Asking them directly is the first step. Are you having thoughts of ending your life? Are you weary of life? I really want to point that out because there's this kind of a myth that if you ask someone if they're suicidal, you might plant the idea in their head. The fact is, people aren't that plastic. When you ask that question, you're letting that person know that you're concerned. You're letting them know that you are someone they can come to if they're having those thoughts. They might not answer you honestly, right? But even if they don't, you've told them, you've communicated to them, when you do feel like talking, I'm someone you can come to. And that's really important because with depression, people often feel like there's no way to be helped, which is the great tragedy because our treatments are so effective.
What about parents and loved ones? How do they react to this line of questioning, which they might even see as sort of an interrogation?
That's a really good question. So I should qualify it by saying that the family members that we're speaking to have volunteered to be interviewed. We're not forcing anybody to be interviewed. So that's a biased set of people. There might be many people who would see it as intrusive, but they're not reaching out to us. So when we're talking to families, generally the families find it to be anywhere from cathartic to talk about this to at least a relief. Because, the thing about losing a child to suicide, as opposed to losing a child to cancer or any other terrible thing, is that the community sometimes, your friends sometimes don't know how to approach you. They feel nervous about it. It's easy when someone loses a child to, let's say, cancer. You go, you give them a hug, you bring food. But with suicide, there's this odd stigma to it. They don't really want to talk about it. And so many of these parents haven't been able to really talk to even their closest friends about it. My team, the people doing the interviews, we're all clinicians, either psychiatrists or psychologists with doctoral level training. And so they can talk to us in a way we know how to respond to their grief. We make recommendations and referrals to treatment sometimes. And they really tell us every time how much they benefited from. In fact, in the research studies that we've done, as opposed to the Suicide Fatality Review Committee, we pay people for their help. Just how research works. And every single family has sort of said they don't want the payment. Don't worry about it. I just wanted to talk. We send it anyway. Of course, we say donate to charity, but people really benefit from it.
So it's not just about figuring out the keys to a gun suicide. From what I've read, you can learn about all kinds of things this way. I mean, you're working on opioids, is that right?
Yeah, actually, my largest study is with opioids. That's an interesting study because addressing a problem a lot of people don't realize exists. It's maybe more of a methods problem. It turns out that it can sometimes be hard to determine when someone dies of an overdose, an opiate overdose usually, whether that was a suicide or an accident. What was the intention there? We're living in the midst of an opioid overdose crisis in this country, obviously. The rates of opioid overdose, fatal overdose are going up dramatically, just as suicides are. And medical examiners, coroners, death investigators only have so many resources, so much time to really investigate. And sometimes it's unclear. If they left a suicide note, it makes it a lot easier to figure that out. But that's a rare thing. Most people don't leave a note. And so investigators and family members and loved ones are left wondering. This is an important question because we need to, as public health workers, know what type of death is most prominent or common in certain communities so we can target interventions. If we're trying to address accidental overdoses, the interventions, Narcan, methadone programs, are going to be very different than if we're trying to address a depression, suicide crisis in a community, which is more mental health oriented. So we had to figure that out. In Maryland, where I work, as many as 75% or 80% of overdose deaths are left undetermined manner. So the majority, we don't know, was it a suicide or an accident? So it actually doesn't go into our suicide figures at all. That's unusual, by the way. The average in the country is about 8% of overdose deaths left undetermined. Maryland, like I said, 75 or 80%. And there's a lot of history to that. This study is designed to use machine learning and latent class analysis, basically advanced statistical techniques, to see if we can, based on the clinical data we have on each decedent, make a guess, an educated guess using these artificial intelligence techniques as to whether it was a suicide or an accident. But then we validate that prediction by having my team go and perform these psychological autopsies, get this in-depth interviews with families. We can spend a lot more time with families reviewing records than a coroner or a medical examiner can, so that we can see if our AI was right. And after we've done several of these cases and gotten a good sense of how correct the AI tends to be, we can modify the AI till ultimately we can use tools like this to help medical examiners all over the country figure out whether someone might have been intentionally overdosing or accidentally.
And that's a really important question.
Yeah, because that data ends up feeding into all of our resource allocation. How much does the state put into suicide prevention work? That data is the cornerstone of everything we do in public health for suicide prevention. It all comes down to what are the actual rates? How are people doing it? Who's doing it? Which demographic groups are at risk, et cetera.
One last question, because I could talk about this all day. It's fascinating. Where do you envision your research going from here, and what do you see as potential outcomes?
Well, there are many directions to go. I do lots of types of research, but with psychological autopsy in particular, it's particularly suited to looking at special populations, subgroups within suicide. So I mentioned before, youth firearm suicide, I mentioned opiate overdose. We're very interested in suicides among Black Americans right now, because as we look at the newest data, we're seeing that suicides in the Black population are going up faster than in any other population, especially younger Black Americans. And so we see a suicide rate going up. The obvious question is why? What's happening in that group? And we can make guesses. We can say, like, for instance, I had a paper during the midst of the COVID pandemic that found that Black suicides in Maryland were going up at a much higher rate than white suicides, which actually were going down during the pandemic. We guessed, well, maybe COVID was hitting that population harder. We knew COVID rates were higher in that population, that was a population that, because of socioeconomic pressures, were less able to work from home, that kind of thing. But we were just guessing. So now we can go back and interview the families of these folks who passed away and get a sense of, well, what was going on with your loved one? Did it have anything to do with COVID? Was it fear related to the racial justice movement that had been reinvigorated? Or was it just they were going through a divorce, or they were drinking more, or, what was going on? It can answer those questions in a way that no other methodology can. We can't get that information just from a physical autopsy or from what we have from the CDC. We need to talk to people who knew these people.
Paul Nestat, thank you so much for joining me.
Thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.